Don't sweat it, we're built for this.
All right, so and some of these slides, as usual, I kind of tap through them a little bit here, but, well, I mean, let's take a look at the objectives of this unit. So what I'm gonna spend, majority of this unit is we're gonna talk about the different classifications of shock. So what's happening to the body, and what do we see when someone's moving into shock? There's a lot of, it's always a pet peeve of mine when someone says, well, I talked to them and they seem to be in shock. And for me, clinical shock is what kills people. So there can be people with a lot of things going on mentally, but when you're not responding appropriately after something traumatic, you're not in shock. Shock is a clinical condition that requires immediate intervention or you won't get better. We're going to kind of just touch on the cardiac arrest resuscitation a little bit, but a lot of the slides for the AED, CPR, treating cardiac arrest, we skipped that section. We went really in depth with that in CPR. I do have AED trainers en route, so I'm hoping that we'll have a lab day that we can be doing CPR and actually have them incorporate the AEDs. Well, I don't know. We will. Okay, so what is shock? Shock, probably the best definition is just inadequate tissue perfusion. So let's kind of break down the term perfusion. Perfusion, I don't know the exact definition, but basically think of when we use the word perfusion, that is how does oxygen and all the nutrients that all our body systems need get that. So when we're not getting effective delivery of oxygen, glucose to the cells so that they can function, that's what can lead to shock. The body will attempt to restore homeostasis. So homeostasis is your body's, is essentially everything's trying to maintain an equilibrium. And we talked briefly, and I'll use the example like the nervous system, our autonomic nervous system, the part we can't control. We've got the fight or flight response known as the sympathetic system, and the feed or breathe known as the parasympathetic system, and they are constantly keeping each other in check. So homeostasis is what allows that to happen. A lot of your body's systems, and there's multiple systems to maintain that homeostasis, there's kind of a, if you can picture like it's a loop. So insult or injury or disease happens, begins to decrease the ability of your body to work properly. Your body initiates a cascade of events to fix or correct that. And there's sensors and everything, just like in your car, the check engine light. There's sensors that are sensing if everything is getting better or getting worse. If it's getting better, it starts to shut things off. And if it's getting worse, it starts to turn more things on. It's kind of to bring it back. So, for example, I cut my arm. Got in a deer and I sliced my arm. I'm bleeding. My body immediately senses that as an injury, immediately begins to send chemical messengers to try to fix that problem. So it's going to vasoconstrict my blood vessels. It's going to take my blood vessels and actually shrink them in diameter, so it's not as much blood coming out. It's going to start, platelets are going to start to form clots. My body's going to start sensing the pressure in my blood that I'm maintaining good pressure, and if that pressure starts to drop a little bit, it's going to start to increase my heart rate to try to keep that pressure in an equilibrium. Well, if I get the bleeding to stop and everything, the pressure and everything gets restored, then all those systems that were activated, the vasoconstriction and all that, they get turned off and they go back to normal. Does that kind of make sense? If it's a really bad bleed and we can't get it to stop, it's going to activate more systems to try to stop that bleeding until the point it depletes those sources, and then we begin to clinically deteriorate. Okay? Just a kind of a quick touch on I'm not gonna dive super deep into the aerobic versus anaerobic metabolism, but in a nutshell, for all of our cells to work efficiently, we should be in what's called aerobic cellular respiration. What that means is that all of our cells are using glucose and oxygen to create an energy source. The energy source, and I don't know if you see it in your books at all, called ATP, that stands for adenosine triphosphates. Not too important for you guys, this isn't something we're gonna expect you to know cellular respiration. There's actually 3 stages that produce this net product of ATP. If we're adequately using oxygen with the glucose molecule, our net is about 36 ATPs for every 1 glucose molecule. If we aren't using oxygen efficiently and we switch to anaerobic cellular respiration, our net product is 2 to 4, I can't remember the exact number, but obviously a fraction of what proper adenosine triphosphate should be. And that ATP, that is the energy that is needed for our cells to reset every second. And I'll use an example like when your heart beats, okay? For every time your heart beats, your cells are resetting every second to create that contraction. To reset that, it has to like move potassium in and out of the cell, and that requires energy for the cells to do that. So you can imagine if we're going from making 36 adenosine triphosphates down to 4, every time we beat, we start to use more energy than what the body can make. And when we don't have adequate energy, then the cells they can't function anymore, they can't move that stuff like they're supposed to, and they begin to just shut down. And then when cells aren't getting that energy, the cell membrane that holds all that stuff in begins to break apart, and all those contents leak out, which can be toxic, in large enough quantities. So, and I guess that's what's kind of getting to the sodium potassium pump, that requires a lot of energy. On top of that, your brain to function requires a lot of energy. So this is where we step in to try to do what we can to maintain that energy production. So even before this, and I'm sure it'll get to it, but a lot of what we're doing with shock management is when we talk about that XABC. So this was, I don't know, probably 8-10 years ago. Before that, it was always airway, breathing, circulation, right? Kind of our priorities. And then with the battlefields of Iraq and Afghanistan, and actually I'll even go back, they've known this even World War I, even into the Napoleonic Wars, they determined there's the 3 leading causes of preventable deaths on the battlefield. Meaning someone died in battle, and that if a couple of things would have been done, they may have survived. And the number 1, close to 70% of battlefield deaths, was hemorrhage. So stop the bleed, then take care of airway, breathing, circulation. So that's why they moved that X up to the top, and that stands for exsanguination. What's a life-threatening bleed? Subjective, and especially with, I'll use my wife for example. Grandkid cuts his lip on something and there's blood on the face and a little puddle on the floor. She sees that as a life-threatening bleed. My threshold for life-threatening bleed is much, much higher. So, and it's super hard, if not impossible, to estimate blood loss. If I put a 500 cc's on the tile floor and I put 500 cc's on the carpet, same amount, going to look completely different. So I always just say if the blood is freely flowing, like it doesn't have to be spurting, if it is just freely flowing, that needs attention regularly. And a lot of these things we can kind of do simultaneously, throwing a tourniquet on while someone's positioning the airway. So we might be doing things kind of concurrently. But with life-threatening bleeding, we need to stop it. And we're going to get it, I'm not going to spend that much more time on it, because when we move into trauma after medical, we'll focus a lot how we put tourniquets on, pack wounds, things like that. But then we move into the airway breathing, and remember, airway is the passageway, so it's the structure that allows air, oxygen to get from the atmosphere into our body. So that's airway, and then breathing is more the ventilation. That's the ability of us to move the air in and out. So oxygen delivery is critical, that we need to maintain adequate oxygen levels. Does anyone remember kind of the magic number for percentage if we're doing a pulse oximetry?
95 or above?
Yeah, 95 is good. We actually, with a lot of my protocols, we want to keep saturation above 93.
Okay.
Now, and why is that? So there's, we're reading, when we do a pulse ox, we're reading how much of that red blood cell, if you will, is saturated with oxygen. Or saturated with something, I should say. Because remember, I can be dead from carbon monoxide poisoning, and I'm going to have 100% saturation. Because I can't differentiate oxygen from carbon monoxide. That with oxygen being bound to your red blood cell, there's also oxygen kind of in your plasma as well. Like oxygen that's kind of floating, it's not necessarily attached. So your oxygen saturation correlates what's called your arterial level of oxygen. So if we did an arterial blood draw, we would look for how much oxygen is in that arterial blood. And we know your PaO2, we call it, that's your oxygen that's dissolved in the plasma, should be between 80 to 100 if we were to measure it. Now that can go 200, 400, it's not a percentage. So there's no cap on how high it can go, and obviously it can go down to 0. But we know 80 to 100 is what's responsible for life. And there's a chart when we correlate that with oxygen saturation, that the difference in your PaO2 when your saturations are between 94 and 100% is negligible. So essentially what I'm saying is if you are 94% oxygen saturation, you have your PaO2, the oxygen is fine. But as soon as you get lower than 92, that curve starts to drop. So for every percent we drop in oxygen saturation, it's an exponential drop in PaO2. So when we notice saturations, O2 sats getting close to that 95, that's where, especially as the EMR, we just start putting them on oxygen quick. There are, and if you talk to people, you can give somebody too much oxygen, but in the resuscitation phase for what the EMR is doing, don't worry about that. So, for example, as a paramedic, we get someone resuscitated, and I got them on 100% oxygen. I'm going to start backing that percentage off, over the next 45 minutes. But for you guys, if they're struggling to breathe, I can't breathe, we're not getting a good sat, just put them on a non-rebreather mask and we'll figure it out. That in the 50, even 30 minutes that you're with the patient, high flow oxygen isn't going to create anything bad. Okay, makes sense? So a lot of times, and we do this a lot, we'll hyperoxygenate people, like before we put a breathing tube in. So even if someone's got an oxygen level of, let's say, 96, 97, and they're in a pretty bad car accident, we're thinking we gotta put the breathing tube in, we will put a non-rebreather on them and just start building this, what we call oxygen cushion. Because we know probably in about 5 to 10 minutes, we're going to be putting them to sleep and paralyzing them so they quit breathing. So we need this cushion for up to a minute it might take us to get that airway in place. Does that make sense? And that's something where I like to tell you in case you're on scene helping and our paramedic says, get them on a non-rebreather. You're thinking, but their SATs are 96. No, that's why, because that medic's thinking, we're going to have to do something here pretty quick. And let's get a big, super big airway cushion. Etiology is a shock. We talked about this stuff quite a bit. As far as the cardiac output, BP is blood pressure. So cardiac output is just a generic term of, is our heart pumping enough blood each minute to get blood to all our vital organs, specifically brain, kidneys, everything that we need. And we've got two ways to adjust it. We can increase the heart rate. You know, that as the heart rate increases, we increase cardiac output up to a point. So if you can imagine if a heart's beating 200 times a minute, what's the ability of that heart to fill with blood? So when it starts beating so fast that it can't get enough blood in to pump it out, that we can get to a tipping point where we can't just keep increasing the heart rate and see a pressure come up with. There's a point where now it's becoming ineffective. And then stroke volume, how we adjust stroke volume is our heart can actually squeeze harder. People, if you think about it, there's probably been a point in your life where you got really scared or something happened and you kind of felt that heavy boom. No, like you're on a dirt bike and you come around a corner and there's a front loader there, nothing like that?
Never.
Okay. But you can, I know I've been there where you feel it. Well, I felt it when you're, any deer hunters? Yeah, what happens when you see a 140 coming up the ridge? You get that. You can feel that, and that's your heart actually squeezing harder, so you can actually sense that. But like kids, pediatrics, like 8 younger, they don't have that squeeze ability yet, but they haven't built that, so kids are really dependent on heart rate, that their heart rate is what adjusts their pressure, whereas adults, our primary means of increasing our pressure is our heart just squeezes a little harder. But shock can really come down to one of 3 problems. So when we think of the human body, it's really no different than a hydraulic pump. So number 1, it's a pump problem, and that's the heart. So things like a heart attack, heart failure, where the pump just isn't generating enough pressure, that's one problem. Second problem is the pipes, the hoses, if you will, that maybe they're too big for the amount of volume that we have. And firefighters, and I know if you're not a firefighter, I apologize, but what happens if we've got 3 hand lines running? We're not hooked up to a water supply, and our tank is less than a quarter. What starts to happen? Starts to cavitate, right? We start to, and you can see it in the fire hose are flowing, and we start to lose that pressure, and that's what's happening when our blood vessels get too big for the amount of fluid. And then the third one is the fluid, the blood and plasma. So if we start to lose fluid, that can create problems as well. So I'm going to just skip ahead of a few. Okay, I'm just trying to see what this is doing. And this is an example. Let's hear anybody. I don't know, snowplow, tractor, skid steer. Anyone ever lose a hydraulic line? What happens? Yeah, quits working, right? Yeah, we start to, and that's kind of when we lose volume. So, volume loss issues from shock. We can get them through a couple different ways, and it's not necessarily just bleeding. So when we look at what's called hypovolemic shock, low volume. Hypovolemic means low volume. Hypovolume, think of that. There's then 2 subcategories of hypovolemic shock. And there's hemorrhagic, which means we're bleeding out, and then there's non-hemorrhagic. So hemorrhagic, pretty self-explanatory. I cut my femoral artery, I got a few minutes, I'm going to lose my blood. Okay? Versus non-hemorrhagic hypovolemia. So this is, I'll just take an 82-year-old female that gets a GI bug, if you will, at some time. So for 3 days, she's vomiting several times a day, profound diarrhea, just losing fluid that her body's not able to take in. So it's dehydrating, which is taking plasma out of the blood. And might have red blood cells, but just losing that fluid that carries it. So that can be an example of non-hemorrhagic. Even take a fever. Remember when I blew on the window when we exhaled? There's carbon dioxide and see that little water vapor? I'm gonna get yelled at by Joe for that. So when you exhale, you're actually exhaling water with each breath. That if I'm I shouldn't say hyperventilating, but let's say I'm breathing fast, I'm sick, I've got pneumonia, I'm breathing, 20 a minute for 24 or 48 hours. That's a lot of water that we can't really measure, that I'm just breathing off. So this is, that's one thing why sick people get dehydrated. That they're just, it's called insensible loss, meaning you can't measure it. Inadequate pump function, so your heart's, anyone ever heard of the term heart failure?
Yes.
Okay, so there's, it used to be called congestive heart failure, CHF, and since then they've kind of gone away with that definition, it's just heart failure. So heart failure is basically when your heart isn't pumping effectively, and there's a lot of things that can cause it. Could be from an old heart attack, could be a current, when you're having a heart attack, that section of heart muscle that's not getting blood supply can't pump effectively, okay? All this can cause some form of heart failure. Has anyone ever talked to someone that went to a doctor and said their heart's working at, and they give a percentage? Okay, so when they talk about that, that's a good thing to know when you're doing an assessment and you're talking to patients. You don't need to write this down, but what they're referring to is called an ejection fraction. Okay, and they get this test through ultrasound. What ejection fraction is if we look at the blood volume that comes into your heart at diastole. So heart relaxes, blood's filling up the heart, right? So right before the heart contracts, we take a look at how much blood is in it. And then when the heart beats, how much of that blood got pumped out versus how much stays. So average, healthy kind of person, it's about 60 to 70% ejection fraction. So meaning that when our heart goes of blood contracts, about 30 to, we'll just say 35% of that blood is still in your heart at the contraction. Now that's a reserve volume, and we're designing it. And that's because if you think about the old fight or flight, a bear hops out, or a saber-toothed tiger, or whatever. That when our heart kicks up, we've got that extra volume to either run or fight. It's the same thing that when you breathe, if everyone just takes a breath in, stop, and then take in more, stop, take in more. You can keep taking in more. We've got reserve volume that we're not even using most of the time, but it's there in case we need it. Okay, so that's what that ejection fraction is. It's just normally about 35% of the blood that comes in your heart stays. So heart failure is defined as any time that ejection fraction drops below 40%. Now, we don't measure that in the field, but if we're assessing someone and we're talking to them and they say, yeah, I was at the cardiologist last week, you can ask them, well, what percentage did he say what percentage of your heart's working? And a lot of times, if they say, well, it was like 23%. And people will they don't understand ejection fraction, but they'll say, the doc said, my heart's working 23%. That's what they're referring to, is that less than 40, they have low ejection fraction, and they are in heart, and they have some form of heart failure. Now, people with heart failure, medicated, right diet, they can function normally, and you won't see them out running, or doing stair climbs, but you can talk to them, they wouldn't know they were in heart failure, but they just need that medication and that support to have the heart function. But kind of 40's that number. So in addition to the heart feeling, there may be things that besides actual structural heart muscle that's not working. There's two kind of terms up here, pericardial tamponade and tension pneumothorax, and we'll kind of touch on them, briefly. But pericardial tamponade usually when we talk about it, it's kind of a, people think it's a traumatic type thing. But you can get a pericardial tamponade from infection. Has anyone ever heard the term effusion? Okay, if, again, you're talking to a patient, they might say, well, I've had a pleural effusion, or I've had a cardiac effusion. What an effusion is just an accumulation of fluid. Okay, so pericardial tamponade, you have a sac, pericardial sac, if you will, that surrounds your heart. And anyone hunting deer knows you got to cut that sac open and get the heart. So that sac, it's pretty tough fibrous sac, but there's a space between that sac and the actual heart. And normally we've got about 30 mLs of fluid in there that kind of just lubricate it so that when it's pumping it's not stable, right? Something can happen, that fluid starts to build up in that pericardial sac. So the sac will fill up with fluid, it'll stretch and get to where it can't stretch anymore. So now it starts to actually squeeze the heart. So now when this heart is trying to beat, it can't really expand very much because it's got all this fluid pushing. That is a pericardial tamponade. So the only difference between a pericardial effusion and a pericardial tamponade is a tamponade is now when it's affecting your heart's ability to function. Meaning, and it doesn't necessarily have to do with the volume of blood that's in there. For example, I've transported a pericardial effusion that had over a liter of fluid in this pericardial sac. So a liter is an IV bag. That's a lot of fluid. He got an infection that migrated in and was basically pus that was filling the sac up. But he wasn't a pericardial tamponade because it happened slowly. His heart was able to adjust with it. He needed to get fixed. You know, he needed surgery to fix that, but he was stable. We've also had where somebody, you can have a stabbing or a car accident where something ruptures that and you start to get blood filling up that cardiac sac, and maybe 100 cc's, so a tenth of a liter gets in there and it stops the heart because it's filled up with blood over the course of a few minutes. So it's not necessarily volume, it's just, I guess when I'm just trying to give you a description of what pericardial tamponade is. Kind of like a tension pneumothorax. So a pneumothorax just stands for air in the chest. Collapsed lung. I'm sure everyone's heard that. So collapsed lung is a pneumothorax. Usually in a trauma patient, we have what's called a hemopneumothorax. Hemo meaning blood. So if I break 4 ribs and I get kicked off my snowmobile, hit a tree and I break 6 of my ribs, they kind of puncture through that lining of the lung, and I start to get air. Because that's trauma, I'm going to have blood in there as well. So you've got air, blood, kind of all filling up, and when it's just by itself, it's a hemo or pneumothorax. But if I got air that continues to leak in and starts building up pressure in my chest, and now it starts to push on my heart, that air pressure is impeding my heart's ability to pump. So when that collapsed lung now begins to affect the ability of my heart to work normally, that's when we call it a tension pneumothorax. Does that make sense? So a pneumothorax or collapsed lung and a tension pneumothorax, same thing. Just one is affecting the ability of the heart to work properly. And we're going to talk about the tension pneumothorax quite a bit in trauma, recognizing it because that is the second preventable cause of preventable death in a battlefield. Giving fluids may worsen the condition. Actually, we have to give a lot of fluids for stuff like that. So. Inadequate vessel tone. So we kind of, and this is that vasodilation type problem. So we don't necessarily see shock from vasoconstriction, but we see shock from vasodilation. And I'll kind of get into what we call that distributive shock. So if you, I think the way to describe it is that if I took a garden hose, turn it on, you see the water come out of the hose about that far, right? So you got your standard garden hose. Now if I took that garden hose and I stuck it into a fire hose, and then I went to the end of the fire hose, what's that water gonna look like coming out? It's barely, yeah, it's just gonna be kind of trickling out, right? Now, if I took that garden hose and I hooked it up to a straw, what's that water gonna look like? Yeah, so that's a way you can kind of think about vasodilation and vasoconstriction. So when I vasodilate, and I make that tube bigger, that's like putting a garden hose into a fire hose, that we don't have the pressure in the back. Versus if we vasoconstrict, that's like taking the garden hose down to a straw. So it's the same volume, it's the same pressure. You know, your pump's flowing at a constant pressure, but we can considerably change that outflow of fluid based on the diameter. That diameter, you may see a term, and this is kind of an EMT term, but systemic vascular resistance. And that is, what are the diameter of my blood vessels? So when I make my blood vessels smaller, I'm increasing vascular resistance. Now, it's not too important for you to dive into that too deep, but that's just what that term means. They're playing my song.
I heard that.
Please don't be a code. Boulder?
Oh, ouch.
Oh, yeah. But those are the calls I like. We're gonna get there, give it all 3 minutes, and we're gonna make it feel.
You know, I watched Grey's Anatomy the other night, the guy's hip popped out, and I watched him put it back in, he shouldn't have it.
Yeah, that's a, Grey's Anatomy is exactly what it's like. You ever been to the doctor, been to the ER, they're all models.
Yeah, I thought so.
Just like Chicago fire.
Actually, my favorite nurses were kind of looked more like trolls, but when I was dying, they were the ones I wanted to look up to, see standing over me. Hip dislocations, this is a pain management call. Relatively non-critical, you feel bad for the guy, but, that ball and socket, when you start to do repair to it, just pop out, either pops out if it pops out the backside, the muscle will pull the leg up, so it will shorten. And the backside, it will actually rotate inward like that. If it pops out the front of the hip, it will shorten and pop up. So anterior versus posterior, what do? We just make them comfortable and take the pain away and give them a hospital. We're not gonna try to pop that back in. Although they're adding to the scope now that paramedics will be able to fix knee dislocations in the field. That would be, we'll just load you up with Versed, pop it back, which I've kind of been doing for 20 years anyway. We just, we gotta get this splint on, so we just, to do it, I just grab the ankle, pull a little bit, and as you're pulling, you just kind of pop that knee back into place. But we were comfortably, make it, as Pink Floyd would say, comfortably numb. Pharmaceutical management. Oh, and I've just got recorded saying that.
Just kidding.
So this is probably in your book, and we'll kind of touch on them, but there's talks about different forms of kind of breaks it down into a couple different categories. So when we're defining shock, we can define it as hypovolemic, like we had said, hemorrhagic, non-hemorrhagic. We've got distributive shock. So distributive is kind of body-wide. And distributive really reflects to where the blood vessels got big, like a vasodilation type shock. And it says neurogenic, septic, anaphylactic. We have obstructive shock. So obstructive meaning something's blocked. And again, tension pneumothorax, pulmonary embolism, pericardial tamponade, and then cardiogenic shock is like pump failure. I don't know why I put the metabolic respiratory, that's usually a complication of shock. So when we're classifying shock, I would just say we're gonna classify all forms of shock into hypovolemic, distributive, obstructive, and cardiogenic. Those are kind of your four big classifications. I talked about that. Pulmonary embolism. Anybody know what that is? Yeah, blood clot. Now, when we look at, in fact, during COVID, you might have heard the term microemboli. Anyone ever heard that term? What does micro mean?
Small.
Small. So, all different types of pulmonary embolisms that we can see. What this is showing, here's the heart, this purple thing is the pulmonary artery, so it's the blood vessel coming from the heart. As it shows a clot down here. So anything past that clot isn't getting, the blood's not able to get into the lung to get oxygen, right? So depending on where the clot is and the amount of area that happens, so the blood kind of hits that and stops, and you get this stagnant blood. We get a bunch of past that it's not getting into the alveoli to offload carbon dioxide to take on oxygen. Microemboli, pulmonary embolism. If you can imagine, down in kind of these terminal ones, we have hundreds, if not thousands, of small little clots everywhere. Versus the really big one, what we call a saddleback pulmonary embolism, and where that pulmonary artery comes out of the heart and then splits to go to the right lung and to the left lung, it can form a clot right there. So no blood can get to the lungs. That's kind of obstructive, that the person's breathing okay, their heart's beating okay, just the blood's not getting to the lungs to get oxygen. That's a very, very lethal condition. We'll talk about it a little bit in pulmonary emergencies, because they'll actually respond. They present with a rapid onset of shortness of breath, that they feel they have air hunger, despite their airway being completely intact. Their trachea, their bronchioles, everything is completely open and intact. So they're short of breath, not because they're not getting structurally or physically getting oxygen into them. They're short of breath because the blood coming back to their heart just isn't able to bring on oxygen. That's due to a clot issue. Otherwise, we already talked about the pneumothorax and cardiac tamponade. Let's finish up like that. Anaphylactic shock. This is that allergic reaction, something we're going to talk about today for epinephrine. So, anaphylaxis is essentially an overwhelming response to antigen of some type. So you can be allergic to something and have sensitivity and have an allergic reaction, and doesn't necessarily mean you're going to go into anaphylaxis. So anaphylaxis is an exaggerated allergic reaction, meaning instead of being localized to the specific area, think you get stung by a bee, it gets red, swollen, painful. Maybe, half your arm gets kind of red, swollen. That's an allergic reaction. But when that system activates your body to just go haywire, and with your inflammatory response, all your blood vessels are going to dilate. They dilate as a response to your body saying we need to get white blood cells everywhere to kill what's ever in our system. And then with those blood vessels dilating, it causes what's called angioedema. So we start to get swelling of vascular structures like your tongue, your epiglottis, your hypopharynx. So that's where in anaphylaxis, the blood vessels get big, blood pressure drops, they start to swell, especially airway structures. They can't breathe, and it can be lethal. So we're going to dive into anaphylaxis specifically, but anaphylactic shock, the big problem there is that they just vasodilate. In addition to, they lose the ability to move air because of structural swelling. Anaphylaxis is one of those things that needs medicine. epinephrine is the antidote. And there's a lot other things, but epinephrine is our rescue med, and that's a skill that the EMR can do. Septic shock, I could talk sepsis literally for hours, I'm not going to, but sepsis can be caused by a lot of pathogens, everything from virus, bacteria, fungus, even trauma. I like to teach, think of what anaphylaxis is to your inflammatory system, sepsis is to your immune system. So sepsis is kind of exaggerated immune response, kind of. As we get some type of pathogen or even a multi-system trauma that activates our massive inflammatory immune response, sometimes that response can be over-exaggerated, meaning that feedback loop I talked about, something's broken. So it's very hard to identify which people are going to move from infection to sepsis. That not everybody who gets a UTI is going to be septic, but a lot of septic people have UTIs. Okay. Just as an example. People who have routes of infection to enter their body. So think of someone at home that's got like a gastric, something put in, or a indwelling catheter, that they're much higher risk because we got this route for essentially bacteria to migrate down that tube to get into the body. So what happens with sepsis is we get this infection, and all of a sudden we get this point where our body says we need to, the whole body needs to fight its everyone. So blood vessels all dilate, we start to lose blood flow to our kidneys, so our kidneys begin to shut down. It's kind of a multi-organ issue. We'll talk about what we can see that may think a person's becoming septic, and this is something our staff really focuses a lot of time and energy into assessing for. Sepsis is probably, I would say, a larger killer in the U.S. than heart disease. Sepsis is, it's very hard to diagnose somebody as septic. Our goal is that we initiate treatment early so that when they culture stuff, they never move into that. So statistically, I'll just throw this up, that if you become septic, so you move from infection to now you're in sepsis, for every hour that you go untreated, you have a 10% increase in mortality. And that's statistically accurate from the sepsis studies. So every hour, 10% increase in mortality. So what? I mean, how many hours until you have 100%? Okay. So you move to sepsis, you gotta move quick. That they deteriorate very, very quickly. So we screen almost every patient, whether this hip dislocation, the crew's gonna do a sepsis screen. We get a car accident, we're gonna do a sepsis screen. We're screening to see if anybody is at risk for sepsis.
How do we screen?
Well, what we're doing is we're using what's called the SEERS criteria. So SEERS stands for Systemic Inflammatory Response Syndrome. So we look at heart rate, respiratory rate, end tidal, and their body. And we're looking for certain triggers. So people, anytime you have a heart rate greater than 90, anytime you have a respiratory rate greater than 20, anytime you have a temperature over 100 or less than 96, so they can actually get hypothermia. End tidal levels, that's that exhaled carbon dioxide, anytime that's less than 32. And then lastly, we're also doing point of care lactate testing, which isn't a diagnostic, and point of care means it's like a blood sugar test, glucose. So we check the finger and we get a lactate. That in early stages of sepsis, with your body trying to fix it, your body has these sensors, and so probably the biggest thing your body does to try to correct shock is you start to secrete adrenaline. your adrenal glands, your body senses I'm starting to vasodilate, my pressure's starting to drop, I'm starting to get a buildup of acids. So we need to increase blood flow and get rid of stuff. So we start breathing a little faster to blow off carbon dioxide. And these are usually pretty subtle in the early stages. Because we're secreting adrenaline, it's going to vasoconstrict a little bit, it's also going to increase the heart rate. But that adrenaline also, it increases what we call glycolysis. So it increases the rate. Our body wants to fight infection, so it starts bringing in more sugar, more glucose into the cells. And the glucose molecule gets broken into what's called two pyruvates, and then the pyruvates go into the mitochondria, which is the
Powerhouse of the
cell.
Oh my God, they said I'd never use that word right. I just did.
And a lot of stuff happens through two cycles. One's the Krebs cycle, and then that moves on to the oxidative phosphorylation. Write that down.
I was gonna.
But this whole process takes that pyruvate, oxygen in the mitochondria, it goes through a chain, and then that's how it creates this adenosine triphosphate. What happens in those early stages, anytime we have, this release of adrenaline, if you will, that when we increase that rate of glycolysis, we start making more pyruvates than what our mitochondria can get. So the mitochondria are full, they're like, we're trying to process this as fast as we can, but pyruvates are just piling up at the door. When pyruvate doesn't move to the mitochondria, it turns into lactate. So subtle increases in lactate tell us that we don't necessarily say they're septic, but we have increased, we have beta stimulation, we have release of catecholamines or adrenaline. Why? So it makes our paramedics start to think, why is this happening? So if we think they're moving into sepsis, basically what we do is we start hyperoxygenating them, start building that oxygen cushion up, and we start giving them fluids. Hopefully we're catching them when they're in that early stage of sepsis, where they're in what's called kind of this compensated shock, where the body's compensating. Where you take their blood pressure, it might actually be high. And you think, if I give you an adrenaline shot right now, what's your blood pressure? It's going to go up, right? So during these early stages of shock, the blood pressure actually starts to get higher because of this adrenaline. And adrenaline is epinephrine. And then we start to run out of our adrenal glands start to run out of epinephrine, and then they just start to crash. So we start filling that tank up before they crash. And the biggest thing we do is we call the hospital and say, we have a sepsis alert. They've hit all these triggers, and then when they come into the hospital, kind of what the hospital's supposed to do is immediately draw cultures, because that takes time to get, and they're going to start them on some broad spectrum antibiotics. Boom. And so hopefully that overwhelming of this treatment early, that we take as they're moving into sepsis, we stop that and shift it back in. Now, if that person doesn't get treatment, they will progress into septic shock. So septic shock is what we're talking about here, where now their body's adrenaline can't keep up with that anymore, the blood vessels are getting bigger, they're leaking, you can't generate the pressure, blood pressure starts to drop, their heart rate's going through the roof. Now they're almost unconscious. Now we've got to shift into more shock management. That's giving high dose medication to really constrict and protect. We use a medicine called norepinephrine, also known as Levophed. Anyone ever heard of that? We used to call Levophed leave them dead, because that is like that was at one point our last ditch effort, where now it's kind of first line treatment. So if you ever see someone with a Levophed or norepinephrine drip, it doesn't mean they're about to die, but it means that they're pretty serious right now. So if they're in shock, we'll start pouring fluids to them, 2 liters easy, and then we'll start them on a norepi drip to try to hold that pressure, and then we probably end up putting a breathing tube in, 100% oxygen. And then they get up to an ICU and they try to fix that underlying infection. But mortality from sepsis is very high. So sepsis is, and the beauty of it, anybody, is prone to sepsis. There's comorbidities that make you higher likelihood, but any one of us, at any time, can get an infection that goes septic. Just like any one of us is susceptible to an allergic reaction or anaphylaxis from bee sting. There's certain foods, certain medications that, you can be stung by a ground hornet 8 times. Nothing happens. And then the 9th time, you go into anaphylaxis. So that's something. Yeah.
Doesn't that make you feel good?
I learned this in my immunology class, especially with like the types of hypersensitivities, like anaphylaxis would be hypersensitivity type 1, not the point, but you have to be exposed to this allergen at least once so that antigen has something to bind to. So like you could eat something like shrimp one time and be fine, but that next time you could, I don't know, go into anaphylaxis.
Immunoglobulin E.
Yes.
So
After
the,
class
um,
switching.
And then that's a really good point. So what happens in anaphylaxis is that we're exposed to an antigen. And an antigen can be bee venom, can be an iodine, can be a penicillin. Those are kind of your common peanut. That those have antigens. And those get into our body. Our body immediately recognizes these antigens as foreign and attacks them. So in the process of attacking it, you actually have white blood cells that make up they almost change their shape, that when that antigen comes again, it can latch onto it and destroy it. And that's why when you get sick, your body for some time, actually, while you're battling that, your body develops these cells that are specific to that virus. So next time your body gets it, boom, it can attack it before it. So to build immunity, sometimes you gotta get sick first. And so that's what I tell myself whenever I'm sick, that I'm just building immunity, I'm building immunity. But in anaphylaxis, so, and I'll just use a bee for example, the venom comes in, I get an allergic reaction, my body senses it, develops cells to recognize it. So a year goes by, I get stung by a bee again. Something triggers an overwhelming, like my body responds 100 times harder than it should, and now it affects my whole body, and I go into anaphylactic shock. But yes, you have to have been exposed to it once before you can develop anaphylaxis.
Okay, so when I was little, I got stung by a bee, and I went into anaphylactic shock. And after that, I took immunotherapy shots for like a year.
Mm-hmm.
So, but nobody ever actually told me what they do. They're just like, oh yeah, now you're not allergic to bees, congratulations. So what do, like if somebody takes those shots, like what do those do?
That's a good question.
In
I could probably get the answer, but not this smart.
Not-
It works to, I think it works to your immune response kind of a little bit more realigned to what it should be doing. And I would say, and I don't want to put the fear like you're all gonna get anaphylactic, okay?
Right.
And like, even with bees, Hymenoptera, if you will, each different type of bee, wasp, hornet, they all have different venom. So it can be a yellow jacket that you have anaphylaxis to, but a honeybee does not. And I can tell you personally, I get stung by hornets, yellow jackets, and it's more annoying, but I get stung by a honeybee. And rarely do I get stung by honeybees because they're beautiful, gentle creatures. You have to generally do something to get stung by a honeybee, but we're beekeepers. So my fault, walking my yard barefoot, I stepped on it. It was excruciating pain, 8 out of 10, for like 3 hours, from a honeybee. Now, a week before, moving wood, get into a yellow jacket nest, I think it's like sting number 8, I realized I moved faster. I step away and within a minute, I don't even know I was stung.
Yeah.
My whole foot got red from the honeybee. 3 weeks later, in the yard again, barefoot, get stung again. My entire leg up to about past my knee swells up 3 times the size of mine. So I know now that I am probably moving to anaphylaxis with a honeybee. Does that mean we're gonna stop keeping beats? Absolutely not. It
Means
just
you're gonna put
means
shoes
I've
on.
got,
Yeah, wearing shoes.
I've got to keep, yeah, don't walk around barefoot.
You have some epinephrine in the house?
Keep epinephrine in, yeah, I know that. Okay, yeah, don't worry about the screening. Neurogenic shock, this is, there's actually a couple different times. So, I haven't seen the term in a textbook, but I was taught psychogenic shock and neurogenic shock. And just a quick breakdown, and then we'll take a quick break. Neurogenic shock is associated with a spinal cord injury. So, if I transect my spinal cord somewhere in my, let's say a T2, so thoracic tube. That low in my spine, it doesn't really affect life function. So, did I tell you, did I ever give you guys that statement, C, 3, 4, and 5, keep you alive?
Yes.
So, the higher up the spinal cord, the more immediately vital to life function. So, you know, for example, like when they would hang people in the out west, hanging isn't a suffocation. Hanging is supposed to be a drop enough to basically separate your spinal cord from your brain. And when you do it at your C1, C2, it's immediate death, usually death. Unfortunately, most hangings now are more suffocation, you know, but hangings are, that's why they put them up on a, you know, drop the door to get a drop to separate that spinal cord. But everything below that spinal cord injury does it now, my nerves can't control the diameter of the blood vessels. So when I lose that nervous control, my blood vessels just won't, they just dilate to they've lost the ability to maintain it. So I've never seen it, but you could literally see a line of demarcation where below a spinal cord injury, red, warm skin because all the blood vessels are dilated, and above that injury, they're pale, sweaty. That's neurogenic shock. Psychogenic shock is essentially what we call a syncopal episode. Something that caused a sudden drop in blood pressure. It's usually due to vasodilation or drop in heart rate. When I talked about like syncope, generally syncope primary cause is something interrupted blood flow to the brain for some reason. So somebody passed out. So when someone passed out, that's a syncopal episode. Think of like the guy who's on blood pressure medicine, he's on heart medicine to keep his heart rate low, his blood pressure low. He's in a dead sleep, and then gets up. Well, when he stands up, you know, the blood vessels are still that big. And he stands up, and gravity pulls the blood down. He's on heart medicine, so his heart can't speed up to keep blood to the brain. And I'm sure everyone at some point has been there in their life where you get up too quick, and what happens? Yeah, you feel like you're gonna pass out. Except if the fact that you didn't pass out means everything in your body worked quick to fix it. Or you sit back down, lay back down, and then get up more slowly like you're supposed to. But people like that, they get up real quick, blood flow can't keep up to the brain, they pass out. That's a syncopal episode. That's psychogenic shock. Or even a response where I'm just trying to think, like if you find some terrible news, and I don't want to, someone comes in and tells you something, someone passes out. That terrible news that just activated your nervous system where you just vasodilated, but essentially what I'm trying to say, psychogenic shock, I think that's why they don't talk, it's really not shock, it's a temporary shock, where it's just a rapid vasodilation, you lose blood flow to your brain, you pass out, and you recover.
What about like a fear response? Like I know people
Yeah.
are afraid of blood.
That's what I was trying to get. So even that with needles, you know, so if I pulled out a needle right now and said, I'm gonna start an IV on everyone in the class, quick, anybody gonna say, I'm out?
Nope.
Okay. And that's perfectly, I'm not gonna do that. I talked about cardiogenic shock already. Okay. I think that's, I already talked about compensation and decompensation, and then we'll kind of wrap it up. But compensation, like we talked, and depending on how what your current status is. So most people in this room, you're working normally, meaning if something happens, your body systems begin to correct, right? So you can have a significant injury. So you're in a car accident and you rupture your spleen. So now your spleen's bleeding internally. Your body senses that, begins to secrete adrenaline, start pumping up your heart rate, start increasing your stroke volume. You start to get what we call hyperdynamic, you get tachycardic, hypertensive, and then all of a sudden you're running out of epinephrine. And you lose that ability to fix it. So now we transition into decompensated shock, which is, this is where you walk into the room and you're like, yeah, they're sick. So they've kind of gone past it. That when someone is compensated, it's kind of hard to tell they're in shock because their body's compensated for it. Then they transition into decompensated, followed shortly by irreversible, which means they're too far gone and you can't get them back. All right, so that's enough for.
Yeah.
We're flying out of here. No, that's the
So we'll go no more than an hour, we'll kind of see how far we get, and then we're gonna, at next break, we'll kind of reset, and we're gonna get into, we're just gonna practice med administration. So, respiratory emergencies, and I will say next Wednesday, that we will just, it's gonna be, we'll just continue the medical emergency. So if we have to do cardiovascular, altered mental status, diabetes, and all that fun stuff.
That's this Wednesday, right?
That's this coming Wednesday. That's 18th?
Yes.
Should be good. Should be good by Wednesday evening, but you know what Tuesday is.
St. Patrick's Day.
Who's
St.
Irish?
Patrick's Day.
Oh, yeah.
We all are.
Everyone knows St. Patrick's
Yeah, it's funny. We didn't set it off and on here.
So we had kind of went into in-depth into the respiratory anatomy, so I won't spend a horrible amount of time, or respiratory system anatomy, I should say. But we'll just kind of, and again, if you got questions like what's alveoli and all that, please ask. But abnormal breathing, so respiratory emergencies, essentially your complaint's gonna be difficulty breathing, I can't breathe, things like that. There's a lot of things that cause it. Even heart-related issues can result in breathing type complaints. So, what causes trouble breathing? If we break it down, it can be structural, which is usually airway, so something that's blocking air from getting out here into our body. So airway obstructions, swelling of our airways, like a obstructive pulmonary disease, like COPD, chronic obstructive pulmonary disease. So let's break that down. Chronic, it's there all the time. So you don't have bouts of emphysema. So emphysema is chronic. When we look at our COPDs, that's the big three are emphysema, chronic bronchitis, and asthma. They're all chronic obstructive diseases. Not all are smoking or vaping, or kids are doing nowadays, but all of them, the underlying pathology is obstruction of airflow through some process. We can have impaired gas exchange. So what blocks these, so let's say our passage is open, so we can move air in and out. We need to make sure we have the ability for oxygen and carbon dioxide to switch places in the alveoli. So if we've got fluid in our alveoli from like left heart failure or pulmonary edema, obviously those gases can't move through water. if we've got like a pulmonary embolism, something that's blocking the blood flow from even getting there, that impairs the ability of gases to escape. And then we have to have adequate ventilation, so our body has to be working good enough to move effective amounts of volumes of air in and out. Because remember, about, of a breath, about a third of it is tied up in what we call dead space, meaning it can't be used. So air that's just sitting in my nose and mouth, that's not, there's no gas exchange. It's gotta get down to the alveoli. So how do we assess breathing? I mean, it starts with lung sounds. Lung sounds are something that just takes a lot of practice. Even when I'm teaching like 12 lead ECGs, which we're not gonna do here, so don't worry about that. But everyone wants to know, well, what does a heart attack look like? What does this look like? What does this look like? And what I was taught, which helped me the most, is don't focus too hard on what disease looks like. Focus on what looks normal. So when we're doing assessments and messing with each other, listen to lung sounds on each other. And you get to know this is what normal sounds like. So then when something's abnormal, it's not really important for you to say, this is what this is. It's more important for you to know that's not normal, right? So just kind of getting used to that, understanding what the baseline is. But breath sounds should be, and we'll say quiet. You can hear the turbulent airflow when someone breathes in, breathes out. You can hear that, you know, that's normal lung sounds. But anytime we start adding flavor to it, you know, some wheezing or some kind of wet, sounds like water in there, those are abnormal lung sounds. We talked, you know, that initial assessment, I usually listen in the armpits, and I'm just getting a snapshot at that point. Anyone remember why the armpits are a good spot to listen to?
Don't hear the heart as much.
Yeah, it's kind of away from the heart, and there's, even on someone who's, let's just say, super obese, let's say a 600-pound person, that even in the armpits, there's not much tissue between the skin and the chest wall. So I don't have to listen through as much, that I can just say we're moving air to the right lung, we're moving air to the left lung. And that's all I'm concerned at that initial point in the assessment. I just want to know, are we moving air into both those lungs? What it sounds like, I don't care. I just need to know air is moving in there. We'll figure out the details later. But when you're listening to lung sounds, and your book probably showed pictures, the back for me is the best spot to listen. Again, less tissue, but I always think of it high lung, middle lung, lower lung. And when I listen to the right, I listen to the same spot on the left. So one, take a breath, and I compare right, left, hot. And then I compare right, left, middle, and then right, left, bottom. And lung sounds might be different right versus left. They might be different high versus low. For example, someone who's got chronic heart failure, it's very common to hear what we call crackles in the bases. And the bases are like when I'm listening, low in the lung, you know, I listen down there and I can hear a little crackly, like water, like a humidifier almost. But when I listen to the middle and the upper portions, it's perfectly clear. So those are lung sounds present bilaterally. I hear some kind of wet sound lower in the bases.
So how do you differentiate that with like an infection if it's heart failure?
Well, it very well could be an infection. We don't know. So that's a really good point. We're not looking to differentiate. We're just telling you what we hear. So like with infection, and I'll kind of get into it, like a pneumonia. Pneumonia is usually kind of clustered to one area of the lung initially. So clear, 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 clear. So my middle lobe on the right, I hear consolidation, congestion, something in there kind of rapid. But everything else is good. With pulmonary edema, or like heart-related fluid buildup, it's equal on both sides. Now, pneumonia, you can have an isolated pneumonia, so I got right lobe pneumonia. Or you can go to really bad pneumonia where it's everywhere. And if I just played a videotape of a bilateral lobe pneumonia and a heart failure, pulmonary edema, they're gonna sound almost identical. Treatments are completely different. You know, not so much for the EMR. You know, EMR, we just focus on getting the oxygen. But therapies like in the hospital, pulmonary edema is treated this way, pneumonias are treated this way. So it's not important for you to really say, oh, I hear crackles, this is probably pulmonary edema. It could just be an elderly person. Well, you think about it, probably the lower third of your lung isn't being used right now with all you did. But when you're breathing, you're probably bringing enough air to maybe inflate about 2/3 of it. That other rest of your lung, that's why when you do a deep breath, like I did earlier, now I'm opening up those lungs. In fact, if anyone's ever been in the hospital and they have you do my favorite, that deep breathing exercise, like when you're in the hospital, that's why they do that. And that's trying to prevent those lung infections. So when your lung is collapsed, and by collapse, meaning not a traumatic collapse, it's just not being used because it doesn't need to be. And if you're paying attention, you'll notice that a couple times an hour, you just, without even thinking about it, you do a sigh, a deep breath. And that's your brain's way, and it just opens that lower lobes just for a little bit. So when the lung isn't being used and it's just sitting there, it still works, everything's fine, but there's very little to no blood flow going through there. Okay? So when you do deep breathing, or like people who do cardio, they tend not to get infections as much because they get to that deep breathing. And when you deep breathe, you inflate all of your lung, you bring blood flow in, and when you bring blood flow in, you're bringing white blood cells to fight any pathogen that might be culturing it. So it's very good to do cardio or to, you know, a couple times a day do those deep breathings to recruit blood flow. This is why elderly, bedridden people get pneumonia so easy, because they're not using that lung. So this little bacteria can culture in there and start to grow to the point when you do get blood flow, it's too overwhelming for your immune system to fight. Make sense? So deep breathing is good. Okay. And it's just gonna look at a bunch of pictures of. So again, you're just kind of comparing right, left. We kind of went over abnormal breath sounds. Now, is it, you know, even EMR, wheezing is wheezing, that when you listen to wheezing, you kind of hear it. It's that kind of, like in asthma, where you think of wheezing, what's happening is your airway, instead of being a pipe, actually turns into a little bit of a funnel through swelling and mucus filled up. That air can get in pretty good, but when it's coming out, it's being forced out of a smaller diameter. That's what makes that kind of weird, that wheezing sound. So like asthmatics and emphysema patients, they get what's called air trapping, where they're bringing more air in than what they're getting out. And that's what creates wheezing. The rales, rhonchi, that's usually some type of fluid, mucus, like when you're listening to a pneumonia, it's basically snot that's rattling around as air is moving past that. Heart failure, it's more water, but it's really hard to, especially with the stethoscope, to really differentiate. Is that water? Is it mucus? You can't. You know, I can't. I just know if I've got abnormal lung sounds, so one portion of my lung like sounds wet, it's probably a pneumonia, whereas heart failure is going to be the same kind of throughout. Just some terms, so both can be problematic. So hypoxemia or hypoxic is lower levels of oxygen, and hypercarbia is elevated carbon dioxide. So remember, both are, it's important to get oxygen in, and it's equally important to get carbon dioxide out. So, for example, a cardiac arrest patient is going to be hypoxic and hypercarbic. So they're going to be retaining a lot of CO2 and they're not going to have enough oxygen. And then we work to ventilate them to kind of restore a natural state. Apnea or apneic, that just means without breath. Dyspnea, you'll hear that term a lot. Dyspnea just means difficulty breathing. That's all the word dyspnea means. So anytime you see PNEA, that's referring to breathing. I'll probably use other terms without even thinking about it. Tachypnea and bradypnea. So tachycardia means what? Fast. So tachypnea means fast breathing. And same, the opposite with bradypnea, slow breathing. So someone who, let's say, took a little too much fentanyl, they're going to be very bradypneic. So very slow breathing to eventually be apneic. And anytime you put A in front of something, it means without. So apnea is without breathing. Now, CPAP, so this is kind of a good slide. So breathing disturbance can be categorized in 1 to 3 ways. Respiratory distress, so what cause that? Inadequate rate and volume, so someone's not breathing in an adequate, they don't have an adequate minute volume. They're not moving the appropriate amount of air over there. So that one video we watched from FOAMFRAT, it can show you can be breathing normal rate, but not good enough volume. Does anyone remember that? Or you might have inadequate rate and poor volume. So it's kind of those two that you got to think. Administer oxygen to maintain SATs greater than 94. I don't know what that's getting at. CPAP, unfortunately, is not an EMR scope of practice, but you'll hear the term they talk about, so that's a EMP skill. So what CPAP is it's continuous positive airway pressure, CPAP. Some people have CPAP masks at home. Essentially what CPAP does is it holds back pressure in the alveoli. So that when we exhale through some disease patterns, those air sacs can actually collapse when we exhale. So what CPAP does is when we're exhaling against some pressure that keeps those air sacs open. Raise your hands if you've ever seen someone with bad emphysema. You'll see them a lot, that they'll be sitting in what's called the tripod position, where they're kind of upright, they got their shoulders out, their arms out like this, and what they're trying to do is increase their chest volume as much as they can, but when they're breathing against pursed lips. So when you're doing that, you're actually CPAPing yourself. You're creating back pressure by breathing. So they just do it before you know it. But they're creating their own temporary CPAP. So then we can put them on a mask, and we can regulate how much pressure is getting back pressure. And sometimes in pulmonary edema, when those lungs are filling up with fluid, a lot of times we can increase the goal is to increase the pressure that's in those air sacs more than the pressure that's in the capillaries. So we actually force the water back into the blood vessels, if that makes sense. And that's how CPAP works. Where the term BiPAP, what that's doing is it's giving you a little bit of pressure when you breathe in and giving you back pressure when you breathe out. Where CPAP is just the back pressure. So when you guys take EMT class next year, we'll learn all about that. Well, and I want to say, I'd like to say this fall, but I haven't had a chance to look at the curriculum yet, and I like to bow hunt. So like if a high pressure's moving in and the bucks are moving and I got to teach, I'm going to be a very miserable person to be in here with. Let's just talk briefly about respiratory. So respiratory distress, respiratory failure. This is something that's actually a requirement that we have to differentiate. So it's kind of subjective. It's kind of like that compensated versus decompensated. There's kind of a blurred line when you transition from distress to failure. So the best way I can define it Respiratory distress is just, I'm having trouble breathing. And there's different degrees of that. So you can be in mild respiratory distress to severe respiratory distress. You know, the mild respiratory distress is, you know, someone, I'm just really short of breath. Just can't, that's mild. You're still talking in relatively complete sentences. Your oxygen levels maybe mildly low, you know, 92%. That's mild. Severe respiratory distress is, I can't breathe. They're speaking in 1 to 2 word sentences. So both respiratory distress, just varying degrees of mild to severe. When we move into respiratory failure, this is where respiratory arrest is becoming imminent, that they are going to stop breathing. The biggest, what I would define as that transition point is their mental status. So if they're still alert and interacting with you, even though difficult, if they're to the point where you walk in a room and you're like, Jim, and they're just looking at a corner in the room. That's respiratory failure, where now it's beginning to affect other systems besides the respiratory system. So respiratory failure is arrest is imminent. And when you see respiratory failure, we're kind of past the point of non-rebreather masks and nasal cannulas. We're now, the first thing we should be grabbing is a bag valve mask and high flow oxygen. And I need you to be mentally prepared that that person, when you walk in, and these are the tough ones for EMS, that you walk in and they're in respiratory failure, they are highly likely they're going to go into cardiac arrest on you while you're there. And a lot of the first responders and EMTs I talk to are like, if I would have done this quicker, if I would have done this, if I would have done this. When you walk in and they're in respiratory failure, you are way behind the 8 ball. And I don't care if you present to an emergency room in respiratory failure, you will go into cardiac, they will probably arrest on ER staff. So this is not, I'm just telling you this is, when you guys walk in and they're to that point, you just focus, we're gonna get going ABCs, but get ready to be doing CPR, because you're probably gonna transition into it. Okay? Nothing, I'm gonna tell you, you can't move fast enough. So there's some comfort. But I wanna paint that because that probably will happen as you go into this. So it's not because of something you didn't do. That respiratory failure, you're walking in at that short little window that they're most likely going to do. In fact, I can count on very few fingers how many people we were able to catch them and get them back into distress before they went to arrest. Very few. So most of them will deteriorate clinically. So just be ready. That respiratory failure is the point where we're going to be putting eye gels and probably get an AD on them and doing compressions. Make sense? And then respiratory arrest, now they've quit breathing, and heart's probably going to stop shortly after. And maybe the heart most commonly is in the process of stopping. So if we have them on a cardiac monitor, and I'll kind of describe to you like if they're in respiratory distress, and I put them on an EKG, heart rate's probably going to be 120, 130, really, really fast. And then they start to move into respiratory failure, and I notice now heart rates are 90, 80, 70, and as they go, the heart rate continues to drop. So the most common cause of really super low heart rates is hypoxia or respiratory failure. So when we have someone with a very slow heart rate and they're not breathing, I don't worry about fix the heart rate at that time, I'm focused on fixing their airway. And a lot of times we fix the airway, we start bagging them, ventilating them, heart rates start to come up and normalize a little bit. But respiratory arrest, the times I've seen people that just isolated respiratory arrest, so their heart's beating, they got a blood pressure, they're just not breathing, I can really, in my experience, 3 times I see that. The most common is a cardiac arrest that we get a pulse back. So we were doing CPR, we shocked them, where now we have a pulse, they're just not breathing. So we have to support their breathing. The second one is opiate overdose. Where we get there, they're not breathing or maybe breathing, taking 2, 3 gasps minute. But they got a pulse, they got a blood pressure. But we ventilate them, give them antidote, Narcan, move forward. Then the third one is a certain type of stroke, like a hemorrhagic. They burst a blood vessel that they just quit breathing, and they have a pulse for it. So if we don't intervene on those patients, respiratory arrest will turn into cardiac arrest. And at that point, you know, if they quit breathing and we can't feel pulses, just start chest infections. We're just gonna move into CPR. And again, I think that's just kind of a good one. I was talking about the alveoli, the air sacs, that's just the terminal bronchioles. So when I'm talking about that's this portion. This is kind of showing that's like the muscle layer that you can actually constrict those airways, dilate those airways. So when we give albuterol, it works on those muscles to relax them and open up that airway a little more. These air sacs are like this, and they're just bathed and they're just surrounded by capillaries on the outside. And you can kind of see how this diagram shows they're like kind of individual air sacs. When we look at like emphysema, those walls between those air sacs begin to deteriorate. So instead of, you know, like this being, let's say, 16, 20 different air sacs, it kind of just turns into one. So we lose a lot of surface area. Is that able to be visualized? But this is what a normal, and again, it's just a diagram. This is showing the emphysema, the kind of destruction of those walls, where it's just turning into kind of one big air sac. So when we lose surface area, that's we cut down half to almost 2/3 the amount of area that capillaries are able to pick up blood. So we're taking away a portion of that on-load off-load process. And then you can see here in the terminal bronchioles, we're getting some swelling, and there can be some mucus production. All that's impeding that airflow. Emphysema, too. Now, emphysema, I mean, you can get it from other reasons, but probably the number one cause of emphysema is smoking. And it's a progressive type thing. So emphysema develops over time. You don't just wake up in the morning. There's a progression to it. You know, and if someone's moving into early stages of emphysema, they can stop the irritant, stop smoking, and can somewhat a little bit reverse that process. And I always say, well, you should just quit smoking. You know, like people who do drugs, you should just stop doing heroin, right? Well, I can tell you, I've been trying to quit chewing for about 20 years. Easier said than done. So to tell someone you should just stop smoking seems easy to non-smokers. Anyone here ever past smoker? Was it fun to quit?
Really good hangover, so it finally did it for me. But no, it's not fun.
No, I've tried to quit chewing, and at about day 4, my wife just buys me a roll. Says, here. Chronic bronchitis, a little bit kind of along the same line, but a lot of times we use the saying, and this was actually used to be in textbooks, is the emphysema patients we call pink puffers. They get real almost cherry colored skin, but more pink. And what's actually odd is that when you develop emphysema or smokers, your body starts creating more red blood cells. So when you get your blood tested, they have what's called polycythemia, where their body actually just starts, because it's so used to being chronically low oxygen, your body says, well, we need to make more red blood cells, which then makes them more prone to clotting disorders and things like that. So that's why they kind of get pink. The emphysema patients, classic, are real rail thin. They get what's called the pigeon chest or barrel chest. This huge big chest, but there's like no muscle mass to them. Whereas the chronic bronchitis, we call them the blue bloaters. They're typically obese, chronically cyanotic. Both of those disease processes are kind of caused by smoking being the number one culprit. But chronic bronchitis is more of it's not so much destruction of alveoli, it's just more inflammatory mucus production in the terminal bronchioles. Yeah, there's your pink puffer. So the presentation, or how a patient presents to you with emphysema or chronic bronchitis, it's not important for you to differentiate. Emphysema patients are going to be more wheezy typically, whereas your chronic bronchitis are going to be more roused, bronchi, type kind of wet lung sounds. Both are going to be in respiratory distress. And waiting to see if we get in. Asthma. Okay, so asthma is another chronic obstructive disease. Now, asthma, oh God, I mean, you can really go in the weeds with that, but there's even pediatric asthma where, if you've ever heard, sometimes kids develop asthma, but then by their late teens, it goes away. Some adults can develop asthma. Some people are more genetically predispositioned to asthma than others. But asthma, it's usually a trigger. So, like someone with bad asthma, that there can be triggers, anything from excitement, physical activity, noxious. So they walk into a room where people have been smoking, and we've all been in. If you're not a smoker and you walk into a home if someone does smoke, like you know it as soon as you walk in. I know when I'm within 10 feet of someone who's a smoker, if they're a smoker, you can just smell it. And that might be enough if I have asthma, that can trigger this inflammatory response in my lower airways. So with asthma, they start to develop, basically kind of like chronic bronchitis, that excessive mucus production, narrowing of the airways. So the alveoli remain pretty good, but we start to get mucus plugging and constricted airways. Now, I will tell you, asthma, again, isn't something that you necessarily wake up with. So we may get called for, maybe someone's first asthma attack. But generally the symptoms are kind of, they start to have some trouble, and I would say 99% of the population sought medical assistance before it got to the point of bad enough to activate 911. So in my 27 years, when we would go to an asthma attack, every time they pretty much said, I have asthma, this is an asthma attack, my inhaler's not working. So I cannot think of one time that I went to someone that ended up being asthma and the person didn't know they had asthma. The good news is, it's not important for us to differentiate between the three. So all three can have wheezing on lung assessments. All three will present with difficulty breathing. They may have normal to lower oxygen levels, but they're struggling to breathe. We have, all of them should have abnormal lung sounds. So when we listen, we should hear something that's not normal. Now, I do have to urge caution that if they get into a really severe attack, that they may move to a point where their airways get completely blocked. And it's not like an airway obstruction or things like that, but what I'm saying is, like, we listen to their lung sounds and we don't hear nothing. That's what we call a silent chest, and that doesn't mean they're getting better. That means they are so constricted, they're not moving any air through the alveoli. So silent chest, we are at this point typically transitioning from that distress to failure. And good news is that the EMR, there's a handful of things that we can do to start turning this around. So regardless of what COPD it is, the treatments for the EMR are all the same. Okay, so that's a good news. Even if someone's into heart failure that we thought was a bad pneumonia or something, the treatments we do at EMR are okay. They're not going to make it worse. So what do? Number one, we can position them If I take someone who's having trouble breathing, if I lay them flat on their back on the cot, they're going to get worse. So people who are having trouble breathing want to be sitting up as high as they can. So once we get them in the ambulance, which you guys aren't worried about, we sit their chairs up as high as we can. If they're in a house, if they're in a chair, try to get them propped up, sit them up. That helps recruit space in the lung to breathe. We still want to conduct an assessment, so we're going to look in their airway. If we're looking for anaphylaxis, one thing I can do is stick your tongue up. Nate, stick your tongue up for me. Good. Okay, done. He's not an anaphylaxis. The fact that he was able to stick his tongue out tells me if he was anaphylactic, it would be your tongue swells up so much you can't stick it. So if you can stick your tongue out, I could even see from here your tonsillar fillers. Well, yeah, he's not anaphylaxis yet. So I'm not going for my epinephrine. If I have oxygen, I'm gonna, if you're saying you can't breathe, I'm not gonna put the pulse ox on and go, well, do I do cannula or non-rebreather, just do a mask. I'm gonna give you 100% via non-rebreather mask, unless you're losing the mentation where I'm just gonna start working with the bag up 340. But oxygen, and we're gonna try to get a really brief sample history. I wanna know if you're allergic to anything. The good news is that what I'm gonna move to is albuterol, or a nebulized treatment if I have that ability, and you're not gonna run into people who are allergic to albuterol. So I still wanna finish my assessment. I'm gonna listen to lungs, kind of make sure I don't see any visible trauma on you. I might look at ankles. Ankles that are swollen can indicate that they're probably possibly in heart failure. Doesn't necessarily mean they are, but it's a pretty good indicator. And we're going to move to getting albuterol. And albuterol, what that does is that takes those airways and it starts to work on dilating them a little bit. And with oxygen, hopefully we can start to move that oxygen. So even that silent chest, I can listen, you're quiet, and give you albuterol. And then a few minutes later, I listen, now you're wheezing. That's good. That means we're now moving some air.
I've seen several people with asthma, like I babysat my little cousin, laughed too hard. Nebulizer wasn't working, so he put his head in between, he bent over a little bit and put his head in between his knees when he was little. And I saw somebody on my volleyball team who did the same.
Did it work? Yeah, and always, a lot of times I ask patient what works for. What you're gonna get is, generally people who have asthma think they're prescribed an inhaler. So inhalers are kind of a little bit tough, that once your breathing gets to a point of difficulty, it's kind of hard for them to be able to, what they do is you essentially aerosolize that medicine into the airway, and then they have to breathe deep enough to get that medicine down into the lungs. So if they're breathing too fast, too shallow, and they're not able to get that medicine down in there, sometimes that's when those inhalers aren't working, that the medicine isn't getting down deep enough to where it works. You see it more often with children, is they have a spacer. Has anyone ever heard of a spacer? Everyone knows what the inhaler is, right? You put a spacer on it where you actually inject the medicine into this essentially big tube, and then they breathe the air out of that tube. They tend to work. I've only seen spacers with kids. But it's still that the aerosolization from that medicine, it's kind of a short burst, it's a little concentration, so if you don't get it down to where it's got to go, it just inactivates and it doesn't work. So when we do a nebulizer mask or a mouth T, they're both the same thing. Whether everyone's seen what we call the T-handle nebulizers, you got a hose that goes out, you see smoke coming out. I like to just use a mask, so I just put a nebulizer mask on someone because they don't have an arm tied up. So now I got an arm for an IV, an arm for blood pressure. That's why I use a mask. But please know the T-handle and the mask, exact same thing. Anyone remember the oxygen flow through a nebulizer?
Starts at 6 liters, 6 to 8.
6 to 8. Basically turn it on. I usually do 6. If I can see that mist coming out of the mask or the pipe, good enough flow. If it's not misting, then I bump it up to you can't do 7. I don't know the regulator, there's 6 or 8. So if you go to 8, it's fine, if you go to 6, it's fine, you might have to bump it up to 8, but negligible, you just wanna make sure it's missing. So we just give them the albuterol treatment. Worst case, which a lot of EMRs aren't allowed to do this, is epinephrine. So epinephrine is really designed for anaphylaxis for the EMR. When you guys give an EpiPen or shot of epi, you are to give it when you think they're in an anaphylactic shock. However, we sometimes, and I, handful of times have used epinephrine on severe asthma, COPD type cases, where they are close to the point of the silent chest. So, it may be if you're an EMR and you're carrying epinephrine, you're calling a report to the ambulance, severe respiratory distress, their altered mental status, oxygen levels 70%, or administering albuterol and they're not getting better, I may get on the radio and say, if you have IM epinephrine available, administer it. And so you just draw up and you do it just like you do for anaphylaxis. Just checking the time here. Pneumonia, so COPDs, pneumonia, infectious process. Some pneumonias, people get pneumonia and they, self-treat at home. Doesn't necessarily mean pneumonia's got to go to the hospital. Obviously, kids are a little bit more concerning. The elderly are a little bit more concerning that they don't have the compensatory mechanisms yet, and the elderly kind of lose that ability. But when pneumonia gets to the point that it's interfering with gas exchange, that's when we get called. Now, pneumonia, same treatments, oxygen, positioning them. Albuterol is certainly not going to hurt them. Really, about the only thing albuterol shows no effect on is RSV in kids. So, RSV is a specific respiratory virus. I think, hopefully, can stop one of these days. We rarely see respiratory illnesses in the summer. It's usually that Christmas time, January, February, where we tend to see them. But pneumonias, because it's infectious, are generally associated with a fever. They get somewhat febrile. It's there's usually a history leading up to. So, like an asthma attack will, they'll tell you that. I went in the restaurant. Someone had smoking a cigarette in the entryway, and it triggered an attack. LDF got a call. Emphysema patients will tell you, I woke up and I couldn't breathe. I've been working at it, trying to do my stuff at home. It's getting worse. I can't get better. Pneumonia, it's, I got sick about 5 days ago and coughing and hacking. Like when you cough, I ask, are you bringing anything up with it? And if you are bringing anything up with it, what color is it? Is it clear? Is it brown? Is it yellow? Then sometimes you want to taste it.
Oh,
Kidding.
God, Jason.
I do, but I'm thorough. And honestly, like pneumonia patients, I get, my concern is sepsis. So I'm more sepsis screening. Usually a nasal cannula on some of your pneumonia patients. And you would be surprised that, they can be saturating at 91%, 90%. You look at them, they're little mild respiratory distress. You put them on a cannula and within a minute or two, they're 100%. And please know, and I know I've said this before, that when you're treating, you can start with, so if you're not sure, you're always okay doing a non-rebreather mask. But if we start someone on a cannula, and it's been 2 minutes and nothing's getting better, we can switch it to a mask. But we can go back and forth. Don't worry about wasting equipment. So if you start here and you realize, I should have did a mask, well, put them on a mask. You can upgrade, you can downgrade. You may see it where you put someone on a non-rebreather mask and the ambulance gets there, and after they do their assessment, they take the mask off and either leave it room air or put them on a cannula, and that's fine too. So our treatments, sometimes we escalate and de-escalate. And then, we take them off your mask, put them on a cannula, and then 10 minutes later, we're like, well, shit, that was done, put them back on the mask. So there's don't ever feel bad about having to make adjustments to your patient management. Pulmonary embolisms, just a little bit about this. So depending on the severity, some people can have a PE and not even know it, depending on where it's at. But when we look at those severe, like I said, those big saddleback PEs, so there's a lot of diagnostics that even we can't do as paramedics, but what I can tell you from my experience, anybody who has a rapid onset of shortness of breath, without any underlying airway disease, so they don't have any asthma, COPD, emphysema, no history of pneumonia, like literally someone was sitting at their desk at work and all of a sudden they can't breathe. That any rapid acute onset of shortness of breath for me is a PE, is a proven on breath. And there's a lot of risk factors, not moving. So this is why there's concern like with air travel, if you're on a plane and you're not getting up moving, that anytime you just sit and don't move and blood becomes stagnant, it can form a clot. If I drew a vial of blood and it didn't have anything in it, just a vial, and I set it down and I talk for 5 minutes and pass it around, it's going to clot up, right? So when blood's not moving, it clots. It's chunky. So this is where like truck drivers, a high risk for pulmonary embolism. Keep sedentary lifestyles, high risk. Smoking also significantly increases risk of PE. Some of your generation 1, generation 2 birth control pills increase risk. So, especially woman, birth control, been on a long car ride, and all of a sudden you get calls that, we got a, 38-year-old female on Highway 51, husband pulled over, she can't breathe, and they were driving from International Falls and they're going back home to Chicago. I can't tell you it's a PE, that they just formed a massive clot. So, not much we can do other than high flow oxygen, just put a non-rebreather on them, and you got to get them for some type of intervention that's beyond what EMS can do. And lower leg assessment, so people who've had what's called DVTs, deep vein thrombosis, blood clots like in the calf. Like sometimes I'll even ask, hey, I know you can't breathe, but have your calves been hurting all lately? And what that is, when you start to get clots in your veins and your calves, if those clots break loose, they come up into the heart, you can get wedged in the pulmonary artery. So DVTs can be a precursor for pulmonary embolism. Acute pulmonary edema. I know I talked about this just kind of a little bit, but essentially what's happening with this is remember the right side of your heart pumps blood to your lungs. The left side of your heart takes blood from your lungs and then pumps to your body. So this is showing normal, that you got your alveoli and your capillary, one cell. So oxygen and carbon dioxide can move through that, essentially 2 cells pretty easily. What happens in heart failure, in left heart failure, so now that left heart is failing. The left side of the heart just isn't pumping very strong. So it's not, more blood is being pushed in from the right than what the left can get out. So that creates back pressure, right? So as you're pushing blood into that left ventricle, pressure begins to build up and it builds up in the lungs. So with this increased pressure, plasma starts to get pushed out of that capillary. And we can see where here they're touching, where now we get this gap of fluid in there, of interstitial fluid. So now the gases can exchange. And that pressure builds up enough where that fluid
then begins to actually leak into the capillary, or into the alveoli. And that's pulmonary edema. The number one cause being left heart failure. For our treatment, you know, they're probably gonna have wet lung sounds. Chief complaint is usually difficulty breathing. If they don't get chest pain, it's usually I can't breathe. And these patients, when you go into pulmonary edema, look very, very sick. They're gonna be pale, sweaty. It's very common for them to be really, really hypertensive initially. So their blood pressures are gonna skyrocket. I'm talking 240 over 140 during the initial phase of heart failure. What we do for that is we just high flow oxygen, and hopefully ALS gets there quick. They need a lot of paramedic pharmacology to kind of reverse that. So they're gonna get CPAP, they're gonna get a lot of nitrates. And if we don't fix them, where all of a sudden their compensatory mechanisms fail, then the blood pressure starts to drop. Now it's not heart failure anymore, we call it cardiogenic shock. Same problem, it's just now they transition and the treatment's a little bit different. But for us, it's high flow oxygen, as fast as we can, and CPAP is really effective once we get to them. We don't need to go over that.
Quick question,
Yeah.
Jason, back to embolism, does aspirin, blood thinner, help that at all?
No, the clot's already there. So aspirin slows down the clumping of platelets, and it's good for an acute coronary syndrome. I mean, aspirin isn't necessarily gonna hurt, but it's not gonna be.
Okay.
What about a vasodilator?
Well, the risk is that if we dilate, we can break off that clot,
Into your
face
brain.
wedge, but they need pulmonary vasodilators, which we don't even carry them on hand. This is usually a PE. You get them into the ICU and they watch it and they anticoagulate you, so they'll give you IV medicine like heparins and things like that. And if it's bad enough, one thing they do is like interventional radiology, so radiologists, they'll almost like a heart cath, but they'll snake a catheter through your heart to the clot, and then they squirt that TPA. It's the drug they use to break up clots in the heart, and they squirt it directly onto the clot. Sometimes they even try to snake another catheter through the clot with like a net to catch it, and they break it apart. It's nothing we're doing in the ambulance. That's my pay grade's here. Pay grade's way. It's an extremely risky, it's not done. And, you know, an interventional radiologist is really, I don't even know, Jesse, do we have interventional radiology around here? Los Ossicosis? So that would be a patient who's probably be put on a helicopter and flown to somewhere that can do that procedure. Pneumothorax, we're gonna talk about this. Usually we see these trauma, but you can have a spontaneous pneumo, so that emphysema patient, where that bunch of alveoli turn into one big sac, right? And that, if we get a couple of them, they can form what's called a bleb. Clinical term, it's just this real thin wall that just in coughing and that sudden change of air pressure, it can burst. So they can have what's called a spontaneous pneumothorax. Now, it's not gonna be a hemothorax, but they'll complain of shortness of breath, and that's when we listen to lung sounds, and how come we don't hear any air over here on the right? And that pneumothorax can turn into a tension at any time. But what I'll tell you is like a pneumothorax, it's usually, I think it's gotta be more than 30% of the lung collapse before we can even detect it with the stethoscope. And you can collapse about 30 to 40% of your lung and they won't do anything for it, they'll just watch it. That a lot of times the body will repair itself. I think it's when you start to get over 40% that they put a chest tube in. And all the chest tube is it's a plastic tube with holes in it, and you sneak it in there, so that when they put it on suction, and basically when you take that air that's built up, your lung reinflates, and then you just leave the chest tube in until your lung heals the problem, and then you take the chest tube out.
not fun. Not fun. And really, spontaneous pneumothorax is just, we just give them oxygen. If they start to develop signs of attention pneumothorax, which we'll talk about in trauma, the treatment for that is a paramedic level treatment. We have to basically put a needle in the chest to let the air pressure out. Hyperventilation syndrome, something you may see. So most of the time, I'll say 9 times out of 10, when a patient's hyperventilating, it's usually anxiety driven. I would say over half of the time we can do it. Anyone know what Ativan is? Okay, so it's like a Valium, it's a benzodiazepine Emr Class drug, but we use verbal Ativan. So just calming, and a lot of times that literally, you sit right in front of the person and, hey, Renee, we're gonna work on this, so I'm gonna breathe, you follow me. You know, let's just focus on this and start slowing down. So, anxiety-induced hyperventilation, it's not something to be taken lightly. And, you know, they used to teach breathe into a bag, right? Because you rebreathe, what happens in hyperventilation is you're breathing off too much carbon dioxide. You're breathing too fast. And if anyone's ever hyperventilated or seen someone, if it keeps going, what's gonna happen is they'll actually start to spasm. It can almost look like a seizure. And if you touch them, their skin becomes super sensitive. Like you go to check a pulse, oh! In fact, if you did that for about, if I had all you hyperventilate for about a minute to 2 minutes, you'd probably get to see a sink collapse. So let's not do that. But a lot of times you just verbally, that's really all we can do. So having them breathe into a paper bag, we can't really teach it because hyperventilation can be an indication of like sepsis, right? And unless you have had training to differentiate, you know, an anxiety-induced hyperventilation, like with me, it's gonna be verbal Ativan for a few minutes, and then we're gonna give them actual Ativan to relax them. But I will have them rebreathe. I'll put an oxygen mask on them, I just won't turn the oxygen. I just want them to rebreathe some of that carbon dioxide. But we also have, you know, we're also ruling out things like diabetic ketoacidosis and sepsis. So if you have someone who's hyperventilating, it's going to be tough, but the best thing you can do is just talk to them, and we're just going to work on simple coaching. That, hey, we're not worried about anything right now, but just getting your breathing under control. And the reason everything hurts is because you're breathing too fast. So we're going to slow that down. Let's just work on it. And vast majority of the time, that simple coaching works on temporarily kind of slowing that down, buying us time. Make sense? But it can be clinically significant. So the hyperventilation isn't just, oh, they're reacting weird. I mean, it truly needs some attention. Epiglottitis is kind of a pediatric thing, and I talked about it briefly. Honestly, any kid who's having from epiglottitis, I should actually have Jesse talk about this because she's been through it how many times, but what's the best thing this time of year when you get a kid who's croup or epiglottitis?
Cold air.
Cold air. Open a window, walk them outside. So that cold air can reduce swelling. Epiglottitis, however, this typically needs medicine, and medicine that we can't give. But it's not super common. We want to just, the best thing we can do with any kid in a respiratory, be it croup or epiglottitis, is keep them calm. So if they're interacting with mom, hugging mom, you know, they don't want you to, don't try to grab them, because you get them worked up, you make it worse. So we're just going to keep everything calm. Kind of the omnia sign is if they're drooling. So drooling indicates they can't swallow secretions because of this inflamed epiglottis. Those are pretty critical at that point, that we just, I shouldn't say critical like they're going to crash. We just don't want to make it worse. So cold air, no noxious stimuli. So that might be a call. You walk in, they call an ambulance because the kid can't breathe, and you can hear them doing that, and they look at you, and
you know, and they immediately don't want a stranger danger type thing. And you just, okay, and we're just gonna talk to mom, dad, get some information, let the ambulance come and let us know that, hey, and get on the radio if we're a ways out, and just say, hey, the kid's really scared, we're just kind of talking to mom, collecting information at this time. That tells us on the ambulance that, okay, kid's stable at this point, that we're gonna shut the lights and siren off as we approach and come in and everything be really cool. We just don't want the kid to get worked up anymore. Not much therapy we can do. Usually your inhaled beta agonists don't work very well. Just basically keep them calm, and that's with, I'm just gonna link them all together. Your croup, epiglottitis, cystic fibrosis, so we don't see that very much. Your other viral infections, and of course we gotta talk about COVID. Yeah, I think that's about it. So what time are we at? 10:53. I'd say let's, this would probably be a good time. We'll take a break and we'll get into, that'll be it for the lecture. We'll start up with cardiovascular emergencies on Wednesday. And I will email out before class the handbooks for these three if you guys want them. I know on the syllabus it says written test. Someone asked me, there's no written test. Just handbooks if you want them. So take a break, we'll reset, and then there'll be no more lecture for the hands on.